Today, on this episode of The Crossover, we will be discussing healthcare for the impoverished. How can we help? With founding dean of the Roseman University Health Sciences College of Medicine and Presidential Medal of Freedom recipient, Dr. Pedro Greer. Learn how the United States healthcare system is flawed and what needs to change in order to provide equitable healthcare to all Americans of different socioeconomic statuses. Much more on this episode of The Crossover.
Good afternoon, everyone. I'm going to be speaking with my friend and colleague, Dr. Joe Greer, about healthcare for the impoverished. Obviously, a very controversial topic. Let me pull him on. Oh, perfect.
Hey, you figured this out.
Hey, Joe, how you doing?
I'm good, Ricardo. How you doing?
I'm doing all right. Listen, thanks for joining us. I know you're uber busy. I'm going to do a brief intro just while everyone's logging on.
Excuse me, and you're not?
No, I have nothing to do today.
Yeah, exactly.
So, anyway, so we have the pleasure of speaking with my friend and colleague, Dr. Joe Greer. He is a nationally recognized advocate for healthcare equity, which is what we'll be discussing today. As background, he is professor and founding dean of the Roseman University Health Sciences College of Medicine. Previously, Dr. Greer served as professor of medicine, founding chair of humanities, and associate dean at FIU here locally down in South Florida. Dr. Greer also spearheaded the nationally recognized Green Family Foundation Neighborhood Health Education Learning Program. He has received numerous awards. I'm not going to get into all of them or else that would take up the entire half an hour, but most notably, he won the Presidential Medal of Freedom from Barack Obama, one of 500 most influential business leaders in life sciences, AMA Foundation Pride in Profession Award, Bob Graham Center for Public Service Award, Citizen of the Year, National Jefferson Award, and a Great Floridian Award. He's published more than 30 articles and books and wrote Waking Up in America, a book about his own life experiences, including caring for homeless individuals and advising for Presidents Bush and Clinton on healthcare policy. So here today to discuss something that's obviously near and dear to his heart, healthcare for the impoverished and how can we help. So again, Joe, great to have you on and excited to talk to you.
And thank you. And I think the introduction was written by my mother, which, by the way, she said, even if I don't deserve it, don't return
it. That's a good principle. That's a good way to, it's a good motto to live by. So let's start by the just basics here. You know, U.S. healthcare has obviously been a dilemma for decades, and innumerable brilliant minds like yourself have been working on this without a real solution. What is the real fundamental problem with U.S. healthcare today?
The real fundamental problem? That's interesting because RAND just came out with a paper published from their office. And by the way, as full disclosure, I'm a trustee at the RAND Corporation. But that the impact of racism on patient safety. And what they looked at, and this was in Boston, that underrepresented minorities don't have access and rarely have insurance. So they're at greatest risk for adverse effects, especially because they're many times going into hospitals that are very impoverished also. So if you want to really look at the core of a lot of these things, it might be racism. It might be that, you know, we, even within our own profession, Ricardo, I mean, it's sort of interesting. I gave a grand rounds at Dartmouth and they asked me to speak on health equity. And I said, how can we speak on health equity when we don't have equity within our own profession? Now, you and I are Hispanic. So we make up a whopping 3% of American physicians.
Is that it? It's only 3%, huh?
And only 5% of American medical students.
Wow.
And so there's an issue with that. When we were at FIU, 70% of our students only got into FIU because you start a new medical school. You're not going to get, you know, the applicants that you all get. However, 35% were underrepresented minority, were 35% were first gen, 55% were underrepresented minorities. But every single graduating class we had, they had the highest step scores and pass rates in the state. And when we left in 2020, we still had a 20% or 100% admissions, acceptance into ophthalmology, neurosurgery, and with orthopedics. So, I mean, that's pretty good. And I love it when people turn around and say, well, you know, don't we want more minorities to work in minority areas? And I'm saying, well, you look at this, if somebody works their butt off and is academically proven themselves, do you really think you don't need ophthalmology in areas that are, have a pandemic of diabetes? And I remember when I was working up with Lou Sullivan back in the Bush Senior, and it wasn't until 1985 that there was actually even a report on minority health in this country. And the Office of Minority Health didn't get funded until the late 80s. And I remember the secretary asking, or saying that we need more minority physicians, which I agree. And then he said to go to minority areas, and I raised my hand and I said, "Ekumi, but my name is Pedro." And I said, "Do I get the barrio and Bob Smith III, he gets Manhattan? Is that how this works?" I said, we need more minority physicians because we need to represent that part of the community, number one. Number two, we saw what happened during COVID with the Black and brown communities taking the brunt of COVID because they had no medicine, no primary care doctor. And we're all touting the beauty of telemedicine, which was originally created for rural and the poor, and they couldn't use it during COVID because they had no doctor on the other side.
Crazy.
It is crazy. And there was a great paper, of all places, from Goldman Sachs, but it was written, "Health Means Wealth." A healthy populace actually increases wealth in that population. They work longer. You don't have to keep retraining. They're reliable and things of that nature. So we have to, as a nation, decide what is it we want to do. The first step, in my opinion, to reforming health outcomes in this country has nothing to do with healthcare. It's social and public policies. I mean, if you think about it, now I'm a lot older than you are, but when I went to college first, I played football, but then I had to pay at the University of Florida, what was it, like $118 a quarter for 15 credits? I got my kids through college and my daughter through college and law school, and pretty much you have to, either you hope there's scholarships available or you better be fairly well off to be able to afford that. So we got to quit pricing our population out of education. There's too much.
So let me stop you there. Let me say that sounds great. And I totally agree with you. But what are the logistics of that, right? Because at the end of the day, education is expensive. You got to pay faculty, you got to pay research. There's obviously infrastructure. So how do we control and in fact lower tuition for people who want to become physicians, college, medical school, and so on?
Well, first of all, I think that the medical schools of the future, like with the one we're trying to create here, we are not a legacy school like the University of Miami. We can get involved in research, but that bench science belongs to you guys. You have the infrastructure. So we don't have to turn around and say every single new medical school needs, $500 million in just dry labs and wet labs and all that. There's other types of research we can do. We could be the complement looking at it from the primary care perspective and looking at it from, how do we develop new delivery systems? How do we deliver ways that doctors can make an income? And by the way, one of the questions you asked me was about the doctors' salaries haven't gone up and nurses, whereas the cost of medicine has gone through the roof, which is true. And where you have to really look at a lot of this is the insurance companies, which, by the way, what a lot of people don't know, there's a thing called pharmacy benefits management. These are giant companies that negotiate your price of your drugs for the insurance companies. Very interestingly, the insurance company owned the big three, which make up 80% of those. So who do you think gets the benefit, the patient or the company? The company gets the benefit. By the same token, we keep paying higher premiums and higher copays. Somebody's making off pretty well here.
So I want to clarify that just for people listening. So the cost of healthcare has skyrocketed, yet the salaries of doctors and nurses has plateaued, if not declined. So in summary, where is the extra cost? It's going to the insurance companies?
Yeah, the middleman. I mean, like you noted, I mean, there's 30 times higher the rate of hiring of administrators. How many administrators do you need? Can't you?
Which is a whole nother problem. I just want to go over those numbers because you mentioned it. But what I had emailed you was that over the last 30 years, the number of doctors has increased by only 150%, whereas in comparison, the number of hospital administrators has increased by 3,500%. So why that discrepancy?
and we have a marked shortage of doctors in this country.
Yeah. So what do you think that's due to? Why are doctors' salaries the same or lower? Employment is the same or maybe a little bit up, and the administrators are booming.
Why?
How can we stop that?
Well, that's the nature of capitalism. Let me see how much money I can make. And which is fine, but not when it's at the cost of human suffering. So you have to look at that and see how are they spending those dollars? Why do I need so many companies to do quality assurance? Why can't you standardize that? I mean, just by looking at those numbers, you could reduce the amount of money we spend in healthcare just by eliminating 50% of that. And that's still not half of what you need to do. Of the number of
I mean, we always joke around in that at least now it feels like there's an administrator for an administrator to an administrator. And when that administrator gets hired, you need, of course, an administrator to watch that one. And it's this never ending cycle. So I'm glad that we're not the only ones here in Miami. But let's talk about your medical school that is so innovative. Tell us a little bit about how you are different than the traditional medical school and what you guys aim to accomplish.
Well, the way we're different is that we really want to address these issues that occur within our own profession. Number one, let's just look at it like we had mentioned: racism, xenophobia, sexism, and and elitism. The reality is that even though 52% of all medical students are currently female, on an average of a lifetime, a female physician versus a male physician will make $2 million less. So we got the diversity right, but the inclusion and equity we messed up on. For African Americans and Hispanics, as I told you, 5% and about 6% for African Americans. Faculty, I think there's 4 Hispanic deans in the country and 2 are in Puerto Rico.
Wow.
And with African Americans and things of that nature. So we have to be very representative, and we have to look at ourselves. And then we have to look at ourselves and say, how do we want to educate our population? I'm in a region that it ranks 49th in the country in number of physicians. So I have to produce physicians. So how do I get a physician to want to stay in Las Vegas, which is a complex problem because you only have about 500 students a year applying from Nevada to medical school. So everybody's talking about GME, but the reality is I think that if I recruit like we did at FIU, first generation, and have proper education. And then the whole thing we were talking about, racism, sexism, xenophobia, elitism, we try from the very top. I'm Hispanic. I'm the dean. Of the 6 of us that came out here originally, 3 are African Americans, 2 are foreign born. I'm including Canada, but it's still a foreign country. It goes good with the statistic. But you have to do this from the very top, to the point where not all our senior faculty are MDs. I have Dr. Maren Gillis, who is a European-trained philosopher and chairs the Cambridge Consortium on Bioethics. Why? Because we need to teach our students critical thinking. Medicine is moving at a very fast pace, and medical education has to keep up with it, or at least prepare the student for those changes. The other one is we have a very strong department here on analytics, because analytics are a major aspect of quality of medicine from the doctor perspective. The patient perspective on quality is very different. The patient perspective on quality is how they are treated. It's almost like a customer service. It's how do I treat somebody? Because think about it. Have we changed the way we see patients? They come in. I'm a gastroenterologist, and they come into my office. What do? You tap on the window. It says, please don't tap on the window. Just ring the bell. Nobody answers. Finally, they do. They hand you either an iPad or a clipboard to fill out. Then you sit there and you wait for another 20 minutes beyond your appointment time or more. Then you get stuck in a room with a gown that's like an HMO because it doesn't cover everything. And you're staring at pictures of diseases, and then there's a tray next to you with instruments in it. And then the doctor walks in with the MA. Does a brief physical exam, quick history. We're very busy, Right now, the average is 28 days to get an appointment with a primary care doctor in the United States of America, which is crazy. So we have to address a lot of these issues. What did we do wrong, and what can we influence society in doing better? If, for example, we developed a tool that follows social determinants of health, 10 domains on a longitudinal basis like we follow medicine. Because why? If they're going to, depending on your socioeconomics, but the poorest of the poor, up to 90% of the causes of the disease are non-biological. But if we can use these markers as indicators in predictive analytics, imagine where I can prevent that. And what we were doing with this household-centered care, because the question we asked was, how do I get to the poorest patient before they show up at the clinic? Because by the time they show up, think about it, Ricardo, if I'm an hourly wage worker and I'm working 2 jobs, I have no benefits, to go to the doctor's 20% less, plus what I got to pay, plus whatever's prescribed for me. And then I got to go back to get the results, because that's the system we've dictated. Why can't the doctor be reimbursed equally by transmitting the information by phone? The quicker they get the information, the happier the patient is.
Of course.
And so it's defined as a interdisciplinary team that identifies and mitigates social determinants. And then we can do behavioral health in the household, because without behavioral health taken care of, you're not going to take care of physical health. And I really think that mental health problems right now are the #1 public health problem in this country. And we see that with addiction, we see that with suicide. And so, we need to start addressing that in a real way, but in a way that's convenient to the patient. And these hourly workers are the core, the essence of what maintains businesses. So we really need to develop a system that keeps them healthy. And if you're in a small little mom and pop shop, you're not going to have health insurance, because by law, you're not required to. And then you got to ask the question again, why do we put the burden of health insurance on the employer? Is there another system that can do it? How do we modify what we have but always maintain the highest quality? Because quality, just because, we do have the most advanced medicine in the world. We have the most patents. But we have to have that. And if we can save money keeping people healthy, I believe that money should be dedicated, and this is policy and legislation, to research. Because research is not inexpensive. And people don't realize that even if you have a bunch of NIH grants, the university's still got to put up about almost equal the amount.
Mm-hmm.
But that's how you need to maintain both sides of the science going, so that we have listen, we keep saying, we want to be the best. Well, we're not. We actually are 36th in health outcomes, and sometimes even lower. So we have to relook at ourselves and say, do we really want to be the best? I do.
Well, let me ask you a question to that extent. And you mentioned it briefly during your response, right? We have terrible healthcare coverage, meaning that a large proportion of the population doesn't have access to healthcare. And you mentioned that, and that's 100% true. However, the quality of our high-end medicine in this country is, if not the best in the world, one of the top 3. I'm talking about complex orthopedic, cardiac surgery, brain surgery. Can you realistically, and this is one of the arguments, can you realistically expand coverage and maintain the highest quality for the super subspecialized care that we do well? Can those two go together?
100%. You made that argument when you said, in the last decade, 3,500% increase in administrators. How much money is that? Is not by making the most efficient system allowing us then to take care of everybody and maintain the pace of science we have. The money's there. It's just how we distribute it. And you have that 10% of our patient population, which makes up almost 85% of the cost of the patient population. A lot of that based on social determinants, a lot of that based on end of life and things of that nature. And we know all those statistics. But if we actually take care of people and keep them healthy with innovative ways of delivery, and one of the things that, for example, CMS is arguing now whether we should keep telemedicine. What are they afraid of? Fraud. Well, if it was value-based, you wouldn't have to worry about fraud, because the doctor would have to figure out how's the best way to keep it. Now, the idea, I love your cup.
Thank you.
It's a cup of you drinking the same thing. I love it. So we have to look at ourselves also, I think, very much from a moral and an ethical perspective. As physicians, are we going to do our part to make this country healthier, or are we just going to keep inventing things? And I was on the transplant team in hepatology. I trained under Gene Schiff. who was one of the greatest mentors. We used to call him Gene the Liver Machine. And I was one of the last fellows with his father who wrote or edited the original textbook. And the idea is one does not have to be sacrificed for the other. We just yeah.
I'm sorry, go on.
We have to decide. You know how much money private equity has invested in healthcare in the last 10 years? $750 billion. The next bull market is going to be healthcare. There's money out there. And if you're having private equity investing, which is sometimes very concerning because you want to make sure the quality's there, that it's just not for profit. It's just not about the return.
So number one, how do we measure quality amongst healthcare, right? A very difficult concept. That's the first part of the question. And the second part is, do you believe in a fee-for-service system or a value-based system?
I believe in a combination. I think a value-based system is very beneficial to primary care. They could actually make more money too, because they're taking risk and but they have to learn outside of what we were taught in medical school, the social determinants of health. And it's not that the doctor has to resolve it. The doctor has to know what are the resources there to be able to take care of these things for the patient. If I'm doing a hip replacement and I didn't bother to find out that the patient lived in a hoarder house and had no transportation, couldn't do rehab, he's going to be she's going to be readmitted within 30 days. And guess what? Nobody gets paid. So, I mean, these are the rules that are existing there. Where the value-based system is in the super specialized care where it doesn't work. That has to be fee-for-service, and you have to carve that out. But for the general population, yes.
But how do you measure quality, right? Because every physician is different. Everyone, let's just say, for example, right, you're measuring, and I'm going to use something that I know about, let's say neurosurgery, right? You're comparing two neurosurgeons. One is at an academic center and handles the complex stuff that the general neurosurgeons don't want to handle, versus the general neurosurgeon who's handling relatively simple or the simpler part of neurosurgery. How do you measure their outcomes? One's handling something much harder than the other.
Scientifically, you can do that with the more complex patients. You know, you can't measure them. It's not apples and apples. So you can't do that. But from a primary care perspective, it's very easy. How have your patients' hemoglobin A1Cs? How are they done? Do you check them? Did all your patients get the screening that they were supposed to do? Not just did you recommend it, did they get it done? You know, there's a lot of these measures that can be done to make sure we do it right. Are you taking appropriate blood pressures? Is the blood pressure being controlled? Is the screening test being there? And, you know, those type of things we can measure. Within the super subspecialties, like I was a gastroenterologist, you know, somebody's got to really look and see, you know, let's face it, Miami has twice the Medicare fraud as the rest of the country combined. It's a little too entrepreneurial in medicine away from the science. And having been involved in that. But having said that, there's excellent practitioners in private practice in Miami and all around the country. But there's quality measures to what you do in gastroenterology too. You know, am I screening appropriately? Am I following a hepatitis C patient appropriately? Am I getting their alpha fetal protein and the ultrasound every 6 months as I'm supposed to? And that's very much in a preventive mode. Am I screening for hepatitis C in the baby boomer population, which I'm supposed to? Am I screening for X, X, and X? So yeah, those are quality measures we have. Now, the patient should be able to see all these, but the patient cares about how they're treated. You know, that becomes, to me, is one of the admissions issues in medical school. How well can you communicate? Because, Ricardo, the future of medicine is going to be very different than the way you and I were trained. All the algorithms pop up there. I mean, for any drug interaction, I just look at my phone. I don't have to memorize Goodman and Gilman. And so it's going to be, how do we translate the information there? How do we train the doctor to figure out which patient is the outlier in that algorithm? That's the type of things that we need to do. And we need to do that by bringing in students, and my personal opinion is on an undergraduate level, they need to take more liberal arts. They're great at memorizing, Then the other question comes in, is a medical school such as mine that is here to produce clinicians, how much basic science do I need?
Yeah, I would say 1 year max. I would say,
Yeah.
which is what most of the med schools now. There's a big push to shorten med school down to 3 years, which I totally agree with.
Well, they've already done that at NYU, Long Island, and I think Michigan State, and it makes all
Correct.
the world. And what I'm thinking about too, now that we have more and more health systems, why don't the health systems work like the National Health Service? In other words, I'll pay your tuition. When you're done, you come work for my company for the a fair market rate. That way you keep doctors in the community. And if you're a big system like Geisinger, Kaiser, or Intermountain, or Renown, you have GME programs. And these are very high quality programs that do a lot of analytics. They don't always get it right, but that's how we're learning and doing it.
Now, let me ask you a controversial topic in the sense that, what about the litigious nature of this country's healthcare? A lot of doctors practicing, defensive medicine, fear of lawsuits, over ordering exams, overly cautious to the point because everyone can sue everyone. Do you think that, first of all, that's a problem? And second of all, how do we address it compared to other countries that don't have this problem?
First of all, we have to do something about that, definitely. But we live in a country where anybody can sue anybody for anything. The other thing that we found out was in California a few years back, they reduced the burden for doctors, but the doctors didn't reverse their behavior. And one of the reasons we found of that was the supply and demand. There weren't enough doctors. If you're a neurologist and you're getting 7 consults acutely, you're going to ask for that MRI before you get down there. So
Absolutely.
So it's a complex series of things that are going on. We don't have enough providers. We're overwhelmed, and we need to do something about that.
Now, let me start by saying, what do you feel about socialized medicine? Because anytime people talk about U.S. healthcare, they're always like, well, England, Canada, these socialized medical systems where everyone has quote unquote access. However, that access can take forever. And the people that have money in those countries and can afford to come to the U.S. for complex procedures always do. So what are your thoughts on socialized healthcare?
In both of those countries, they also have private practice. So those that have money can also afford a private practitioner there. So they don't have to wait. It depends how you look at it. If you look at it as it's taking a long time to see a doctor or you don't get the choice, that's true. That is lost. But that's the same thing if you join a Medicare Advantage plan. You're stuck with whatever they have and however that system works. But their health outcomes are far superior than ours. Now, having said that, we also have to look at social and public policies. Because if you have an educated populace, you have a much healthier populace. There was a paper written in 2017 by Ann Chase. She's an economist from Princeton. And it was called Deaths of Despair. It was the first time in 100 years, with the exception of a little blip in the 60s, that morbidity and mortality was markedly being increased in the United States. And when she broke down the groups, it were mostly baby boomers. The increase in rates of morbidity and mortality were mostly non-Hispanic white baby boomers. And the 3 leading causes of death were suicide, opioid overdose, and alcoholic liver disease, along with all the other things that this population is. And when they looked at the social determinants between the different cohorts, those that the curve was going straight up never went beyond high school and were mostly rural. And as a friend of mine, an anthropologist explained to me, he said, Joe, the rural America is becoming the new inner city. That's where we're having all the drug problems, where you're looking at all the subsidies and all the things that are going on. So these are social problems that end up on our doorstep. So, I mean, one thing is say, let me stay in my own lane, or let me do something to improve the health of somebody by trying to mitigate these things with the resources that exist. That's what we're doing differently here. You know, I mean, and I saw this, the importance of social determinants when I did my first working on a study with Dr. Schiff where he had saved all the blood from the Cubans from the 1970s that had come in here that had hepatocellular carcinoma. One of the reasons I went into hepatology was Cubans had twice the rate of hepatocellular carcinoma as the rest of Americans. When Cryon Labs discovered the antibody to C, we retested it. It turned out to be about 80% were positive in the first generation Hep C test. So these Cubans were all coming in here because they had hepatitis C. When you broke down the socioeconomics, they were mostly of upper middle class and wealthy families. And why is that? Cuba's fanaticism with health. So families that could afford it had their own syringe and needle, which they boil for 10 minutes. But everybody got vaccinated. Everybody got B12. But if one person had what we used to call non-A and not B, guess what? Everybody was exposed to it in the household. So there's the social determinants again. So if we had let them know that they had to boil the needle for more than 10 minutes, we wouldn't have had that epidemic.
In your opinion, what country has the best healthcare currently?
The best healthcare overall?
Yeah, like if you could just say, let's just change the U.S. healthcare and start with, emulating another country.
The problem with the U.S. healthcare is we're actually 50 countries. So,
yeah.
And we're very much believers in state rights, which I am too. So we have to do something, but we need to do something so that if somebody moves from one job to another, they're still covered. Where insurance companies say, well, since I'm not going to have them in 50 years, why should I do the screening test? There's a lot of these things that conflict with each other from both an economic perspective and a policy perspective. But the bottom line is we are responsible to take care of the population. And one of the things we do with our students, because one of the things I said about medicine is we're elite, is we are elite in academic medicine when you know that the average medical student's family makes 2 to 3 times the national average. But yet we're going to require this individual to take care of an entire population. So actually, when the student goes into the household and they follow it, that's the other thing, 4 years of following an entire household medically. Something that you don't do in medical school normally, but you're going to do the rest of your life. And the student is never allowed, the medical student is never allowed to ask, how do you feel? They have to ask, what is your most urgent need? So the student can get into their perspective that, and as I explained to them, I go, look, you guys, I'm a gastroenterologist. I've been one for over 40 years. Let me tell you something. I've been asking that question for 30 years. Nobody's ever said a colonoscopy is the most important thing they need, the most urgent. Why is that? Because when you can't pay your rent, when you have a kid that's an addict, when you're going through divorce or somebody's taking your house away, guess what? Getting your colonoscopy is not the most important thing in the world, or your mammogram, or any of your other screening tests. So the understanding that not everybody, for us to go to the doctor, we're still getting paid. And guess what? Somebody's paying for the doctor. So we have to make it accessible. How do we expect these that's why I'm going for the first gen students. They're the first ones in their family that will have the opportunity for generational wealth. What an opportunity to give somebody. My father was the first one in our family to finish high school. And he saw his granddaughter graduate from Harvard Law School. Un guajiro, that was a doctor. I love my dad, God bless his soul. De Pinar del Río, de los Arroyos de Mantua, gets to go to Cambridge to see his granddaughter graduate from Harvard Law School. And, that's the importance of education and giving these opportunities. If it wasn't for my father, I would never be in this position. My daughter wouldn't be in her position, And so it's the more, as we deliver healthcare, and the reason that it's so important to deliver this healthcare to the greatest that need, because they're the ones that I think bring all the opportunities in this country for us to keep getting better.
Let me ask you one last question, because I know you're super busy, and I just want to wrap it up and kind of summarize. Let's just say you're President Biden, and you're running the administration. Clearly, you believe that healthcare needs to be revamped in a grassroots effort. It's not just administrators or policy, but it's really a systemic social revamping. What is the number one move that you would make if you were President Biden's administration to help improve the healthcare system here in the U.S.?
Well,
Tough question, I know.
it is a tough question. I guess today the most important thing I would do if I was Biden was start lighting some candles for the midterms, because he's not going to get any policy changed.
Yeah.
But I think we have to really look at, my goodness, because most of the reality is most of these things are at the level of a local or state level. Transportation is a county issue. But I mean, one of the things that I used to see in Dade County, if you had to take 3 buses to get to the FQHC clinic, or 2 buses, and it's August, it's hot, and you're walking, and it's raining or not, it's hot and humid. And let me tell you, when you walk into that clinic, your blood pressure is going to be through the roof. So transportation becomes a big issue. Education. And I would be encouraging federal support to be able to get those social things passed. When I say social, I mean, going to school, getting an education, things that the idea is to bring people to full resiliency, to allow them the opportunities that this country offers. I am dedicated to working with the poor. This is all Catholic schools, social justice. That was beat into me. And then I'm also a generation of the 60s and the 70s where we were going to save the world. And then everybody in my generation ended up getting stoned and didn't do anything. But the idea is that
it started out with a really good intention, though. That's what matters.
Yeah, exactly. But we got to continue that. We got to continue that. I think that we as professionals should be leading that. We should be the humanists of our society. We should be the ones that are not just physicians for individuals, but physicians for the society.
Joe, what an amazing interview. First of all, kudos to you and the Roseman University College of Medicine for what you guys are doing out there. It's really innovative. And I hope that people follow suit and that catches on. And I think your message could not be stronger, in the sense that improving healthcare in this country is not about policies and stuff done at a very high level. It's really grassroots. It's racism, it's systemic policies, and it's getting the minorities more involved, which, just like you said, was only 5% Hispanic and 6% African American, you said?
Students, yeah.
So clearly a lot of work needs to be done. And thanks for everything you do, Joe. It's very, very inspiring.
Well, thank you. And thank you so much for inviting me. And congratulations on the great doctor that you are. But if you're the king of cranium, then I'm the grand poobah poop. So.
I'm going to have to do another Instagram post on that. That's perfect.
What's poop to you is a living for me. Look at it that way.
There you go. Absolutely. All right, Joe. You have a great weekend, buddy.
You too, man. Bye-bye.
Take care.